All right, good morning. It is February 2nd. This is Senate Health and Welfare Committee. And today we're looking at S206, which is a bill related to patients with cognitive impairment. We have another number of folks testifying today who are with us. And then we'll be looking at a couple of other bills that we've been working on related to mental health issues. So it's a full day. I'm going to ask everyone to be as complete but concise as you can be. We don't want to miss things, and we will be good listeners this morning simply because there may not be sufficient time to ask all the questions that we have, but we certainly are interested in everything that you have to share with us. So this morning we're going to begin with Meg of the Alzheimer's Association Vermont chapter. And welcome back to the State House. It's good to see you. And then we'll move on to some constituents of Senator Hardy from Senator Hardy's district. And I'm going to ask Senator Hardy to introduce them. So Meg, why don't you introduce yourself for the record and go ahead with testimony.
All right, thank you so much for this opportunity to speak on S206. My name is Meg Polite, and I'm the Policy Director for the Vermont chapter of the Alzheimer's Association. Before I speak to specific parts of the bill, I wanted to reinforce the importance of addressing Alzheimer's and other dementias, and also share some of the work that's currently happening here in Vermont that you may not be aware of. Alzheimer's is a public health crisis in the United States and here in Vermont. Right now, there are more than 13,000 Vermonters over the age of 65 living with Alzheimer's, and that number is projected to climb to 17,000 by 2025. Nationally, Alzheimer's and dementia deaths increased 16% during the COVID pandemic. It kills more than breast cancer and prostate cancer combined, and it's the fifth leading cause of death in Vermont, and we have no cure. In 2020, Vermont had 25,000 unpaid caregivers supporting family members with Alzheimer's and other dementias. The value of that unpaid care was $717 million. Approximately 2/3 of caregivers are women, and more specifically, over 1/3 of dementia caregivers are daughters, and you're going to hear from some of them today. Alzheimer's takes a devastating toll on caregivers. Compared with caregivers of people without dementia, twice as many caregivers of those with dementia indicate substantial emotional, financial, and physical difficulties. The problem looms large, but we've already started to address it, and we are seeing positive outcomes due in part to currently having a statewide program manager. In 2020, Vermont was the recipient of a 3-year Building Our Largest Infrastructure, or BOLD, grant from the CDC. That grant has allowed us to hire a statewide manager of our Alzheimer's disease and healthy aging program, and it's showing us what we can accomplish with statewide coordination and the impact that can have on increasing our public awareness, early detection, and diagnosis. I just want to highlight a couple things that have been accomplished in less than a year with that kind of coordination. We now have a monthly Alzheimer's and healthy aging electronic newsletter that provides a centralized system to inform providers, caregivers, and agency staff with the latest data, projects, and resources. The Department of Health has launched Project ECHO, which is an 8-month virtual education series to help build capacity for dementia diagnosis and care. Vermont Health Learn, which is a free online educational tool, now has a dementia diagnosis and management curriculum with 27 enrollees. And we have a program now called Dementia Corner Consults with Dr. Pendlebury, the medical director of the UVM Medical Center Memory Care Program, and he provides time to meet with primary care providers and their teams to help with consultation. In addition to all of that, 3 years ago, an Alzheimer's and healthy aging work group convened, and they've been instrumental in establishing a hub and spoke model of care with the goal to reduce hospital admittance of those with dementia. So all these programs require coordination, and what we're doing is working, measurable, and has a direct and positive impact on those with Alzheimer's, their caregivers, and their medical providers. We must ensure that this legislation paves the way for the continuation of a full-time statewide dementia coordinator. So a few comments on the specific bill S206. It puts the creation and assessment of a state plan in the hands of the Commission on Alzheimer's Disease and Related Disorders, the ADRD. I've witnessed the work of the ADRD over the last 6 months and strongly support the annual report they created and shared with you earlier this year. The commission is composed of members who are informed and actively participate. That said, I do not believe they have the authority or resources to complete the charge this bill sets for them. It's my understanding that commissions serve as resources and advisors on issues. If you review the annual reports from the ADRD from the last several years, you will see they've been making strong recommendations for investments with data-backed reasoning. They've asked for support and coordination, but those reports have not resulted in policy or program changes. I see this bill gives them a new and different charge, and I fear they will fall short without the resources needed to complete it. This work, and Vermonters with Alzheimer's need staff and funding to address this issue with the seriousness it deserves. The bill proposes to require the Commission on Alzheimer's Disease and Related Disorders to produce an assessment and state plan to overcome Alzheimer's disease. Our BOLD grant that I spoke of requires us to create a statewide plan, and we've been working with stakeholders on this. The plan is set to be released in May of this year, 2022. And while some members of the ADRD are part of the BOLD process, I'm not sure these two requirements are interchangeable. I also would like to flag the word overcome in all sections of the bill as it relates to Alzheimer's disease, and I suggest you might change it to address or respond to. Finally, I have concerns with charge 3 that allows physicians to disclose diagnosis and treatment plans. We know there's a reluctance on the part of primary care physicians to make diagnosis of Alzheimer's or other dementia. And one of the reasons we hear from them is because they feel unprepared to support the patient and their family. We are working really hard to increase the rate of diagnosis, and I worry that this parameter could make that more challenging. As a member of the self-neglect working group formed by the Older Vermonters Act in 2020, I know there is great concern about the lines of safety, self-determination, and negligence. So I believe that this charge should be removed from the bill. I also do not believe charge number 4, requiring hospitals adopt an operational plan focused on patients with dementia, makes sense at this time. I'm very supportive of that happening, but I'm sure your committee has heard about the severe staffing shortages at hospitals, and I don't think this year is the time to mandate it and would not advocate for it to remain in the bill. I strongly agree we need a statewide plan. We need regular schedule for when it's updated, maybe every 3 to 5 years. I'd like to say an alternative to charging the ADRD with creating this plan could be to require a section specifically related to Alzheimer's disease and other dementias be included in the state plan on aging, which the Department of Disabilities, Aging, and Independent Living is already charged with updating every 4 years. Maybe the ADRD could be required to contribute or approve of this plan. Most importantly, we need a statewide coordinator to ensure that the work we're doing continues and that we have the structure needed to receive future funding. Thank you so much for dedicating your time to this cause. You have the opportunity to put forward legislation that will make a huge difference for Vermonters with Alzheimer's, their families, caregivers, and medical providers. And I look forward to collaborating with you on this endeavor. Thank you.
Thank you, Meg. That was very complete and helpful. Can we get your testimony in writing so we can have it for reference as we go
Absolutely.
through the bill? Yeah, that would be terrific.
I'll send it to Erin, and I'll also send the 2021 facts and figures just so you have that complete document for your reference.
Terrific. Thank you. And I'm also wondering, Erin, I'm going to ask you, do we have the ADRD report on our webpage? Has that come to us? Is that a requirement? And Meg, maybe you know, or if you don't, Angela may know.
If I've received it, I've put it up there. I'm not sure, I could check.
Okay, that's good. We'll keep that one in mind. All right, thank you. Quick questions for Meg. We have your comments on sections of the bill. I will ask one question. You can think about it. The one question is removing those numbers 3 and 4. It may be that there's a modification of language that would say when resources are available or when capacity is available, something like that. I don't have it in front of me, so I can't say, but could you at least think about that part? And then we wouldn't have to come back to the full legislature for that decision going forward. Anyway, okay. All right. Senator Hardy, do you want to invite your constituents to testify?
Yes, thank you, Madam Chair. And thank you so much for being here today to talk about this really important bill and issue that has impacted so many Vermonters. I'm really pleased that 3 of my constituents are here. And I first wanted to introduce Pamela Smith and her daughter, Erin, who are constituents and also neighbors of mine who live right down the street from me in East Middlebury. And I met with them earlier this year and they shared their story with me, and I'm really pleased that they can be here to share their story. So Pam and Erin, if you want to take it away, that would be great. Thank you.
Sorry. So, dear Senate Health and Welfare Committee members, I'm Pamela Smith. I have younger onset Alzheimer's. In other words, I was diagnosed before the age of 65. I was 52 when I was diagnosed. My diagnostic experience. I began telling my PCP, her nursing staff, and her interns at every visit that I was having memory issues by age 50, after noticing problems myself for about 6 months. I was concurrently having severe anxiety and mild depression. In hindsight, these mental health issues were clearly consequent to and not the cause of my memory problems. But my PCP did not hear me. My symptoms were explained away as menopause or anxiety and depression, too much stress, or because my chronic pain condition was making it hard for me to concentrate. Family members saw I was having problems and had their own theories as to the cause. I admitted to my supervisor that I was having memory problems. She proposed that it was because the job was stressful. Someone in my support group recently noted, with regular onset Alzheimer's, everyone is trying to convince you there is a problem, whereas with younger onset, you are trying to convince everyone else there is a problem. What finally worked for my diagnosis, I was at work one day struggling to complete some paperwork. I'd spent 4 hours writing a note that should have taken me less than 20 minutes. I called my PCP in tears. My provider wasn't available, but a colleague agreed to see me the next morning. He had lots of blood tests, all normal, sent me to the memory clinic for an evaluation. I discovered that my IQ had dropped 40 points. The odd thing was that each medical provider kept telling me that the next medical provider would go over the results with me. The first neurologist diagnosed mild dementia. Then the brain scans began. No tumor. Finally got in with the UVM memory clinic neurologist. At the end of the appointment, when a definitive diagnosis still hadn't been stated, I asked him directly if I had Alzheimer's, and he said yes, and seemed surprised no one had told me yet. It just felt like no one wanted to give me the bad news, that I needed this specific diagnosis in order to apply for compassionate allowance, Social Security disability, and I needed it for my sanity. What does it feel like to have Alzheimer's? Alzheimer's is a process of letting go, mourning, and acceptance. It ended my career. I had to let go of my retirement dreams. I won't write the books that I had planned. I won't get to see the big milestones in my grandchildren's lives. I let go of reading, of following the plots of new movies or TV shows, of using the stove when I'm alone. Soon I'll stop driving. I often feel like I have ADHD, which I don't, because I bounce from one task to another. If I think something is important I have to act immediately before I forget. Some days I actually feel myself slipping, memories dying, losing time. I sit and think of nothing. I am anxious nearly all the time because I never know what I will remember. And I know that most everything I am living, I will forget. The importance of the topic has no relevance to whether or not I will remember it. My world is now blurry, despite wearing glasses, because the issue isn't my eyes. It's my perception of what I see that is out of focus. When I found out about my vision, I cried at the ophthalmologist's office. asking what else Alzheimer's would take from me, knowing that the answer is everything. I'm better now at living in the moment and enjoying the moment, but I also get overwhelmed, impatient, and even angry. There are good days and bad, just as they say, but I can speak for myself and for others who can't articulate their experience. We feel that we are drowning nearly every day and pulling our loved ones down with us. I still have some work to do on acceptance. Some days I feel great. I'm content with the losses and accept who I am and where this is going. I know I have Alzheimer's and not that I am Alzheimer's. The impact on my family. I feel like a burden to my family. I see them hurting and struggling because of me. I know there's no way to get better. I will only get worse, much worse, and each step will cause them more pain. I worry for them. I had never seen my husband cry before the diagnosis. Now it is a regular occurrence. I worry for my son who has Asperger's syndrome and still needs my assistance regularly. And I worry about all the strain I am putting on my daughter, who has to function as my case manager, negotiating systems she sometimes doesn't know. I will never qualify for Medicaid because my husband has to work to support his children. My daughter feels she can't work because she never knows when I will need her, for what, and for how long on any given day. And there is no system in place that can pay her because she is a family caregiver. My daughter has power of attorney for me, including finances, so she can help handle everyday things. I'm lucky that I can still be home alone, but eventually that won't be the case. I'll need someone to feed me and to make sure I don't get lost wandering into the woods during the winter. My 6-year-old granddaughter climbs up on my lap, puts her face to my face, and taps me on the forehead to say, "I don't like that Alzheimer's," when I forget something that was important to her. Case management. I had to be my first case manager. I made numerous calls to multiple state agencies trying to get help. Each agency told me to call another one and why they couldn't help me themselves. Eventually, I figured out there is no real case management for people with Alzheimer's, especially for younger onset, as I was defining case management from my own work experience. I said to someone during the process that I couldn't believe that the person with Alzheimer's was who had to figure out how to get help. Through this process, I learned that I had to pay out of pocket for anything I needed, and that the expectation is that family members figure all this out without any training or compensation for their time. Elderly Services in Middlebury was helpful in giving a concise description of case management with elders. It's called care management for Alzheimer's. Basically, someone who will help you fill out forms for benefits, either for a significant fee or paid by Medicaid. For years, I was a case manager for adults with intellectual disabilities. I need one of those, a comprehensive case management that will help with whatever comes up, including budgeting, filling out forms, attending appointments to ensure follow-up, making sure my meds are right, getting any help that I might need. We rightly have recognized that a person who is born with an intellectual disability needs a comprehensive case manager. Now we need to recognize that a person who acquires an intellectual disability through Alzheimer's or another form of dementia needs a comprehensive case manager. People with Alzheimer's need all medical providers to be trained to look for the signs of dementia and know how to initiate the diagnostic process. And they really need to listen to their patients. We need counselors who are trained and experienced with Alzheimer's to help us and our families navigate the emotional impact. We need cross-training of state and private nonprofit support providers so that a person calling for help can get accurate information about services regardless of which place they call first, and coordination between all the state and nonprofit agencies that help people with Alzheimer's. someone to educate the patient and their family members about how to adapt to each change in functioning. Comprehensive case management available to everyone diagnosed with dementia. I don't yet qualify for Medicare through disability, and Medicare doesn't cover case management anyway. We need someone to help make decisions through power of attorney or guardianship and to protect us from financial exploitation, which I had seen happen to my grandfather. In-home direct assistance for cooking, managing the household, completing tasks, and eventually personal care. We need transportation to appointments, basic needs, and socialization opportunities, and support for family caregivers, including training and payment for services rendered. All services need to be free or reasonably affordable. Most of us with Alzheimer's do not have Medicaid, at least not until our disease nearly bankrupts us. Thank you for listening to my story and caring about those of us living with Alzheimer's, patients, caregivers, medical providers, family members, and the community at large. And thank you for next listening to my daughter's story as well. I'm available to talk further with anyone who wishes via email or Zoom, and feel free to share my story with anybody who's interested. Advocacy is now my life's work, and I want to make the most of it.
Thank you so much. Continue, Senator Hardy. Keep going.
Thank you, Madam Chair. I believe that Erin wanted to add something to her mother's story as her caregiver. So go ahead and introduce yourself officially, Erin, and then go ahead with your testimony as well.
Hi. Allow me to start off by thanking this committee for the opportunity to speak about my experience as a caregiver and daughter of a person with Alzheimer's. My name is Erin McElhaney Smith of Ripon, Vermont. I am 30 years old and a mother of two. For the last 9 years until his death in May, I was the caretaker for my great uncle who had cognitive and physical disabilities from birth. Through the last year of his life and since, I've also been the primary caretaker for my mother, Pamela. These two experiences have some stark differences as well as unsettling similarities. With my great uncle Kirk, I had a team of support. While I lived with him in the home, I was able to use money from the state to hire about 10 hours of work staff to help, to provide him with amazing opportunities outside of the house that I was unable to offer as a young single mother. I had doctors who were able to speak to each other, his case manager, his guardian, his staff, the pharmacy, myself, anyone I needed to, in order to have the continuum of care he needed and deserved. I was also able to get paid for caring for him. And while I have much to say about the needs for better paid home providers and a respite budget that actually makes our lives manageable, I have learned that this time in my life, when I was a poor but paid, overworked but supported, was so much better than what my future held. Now, as the primary caretaker for my mother, it does not matter how hard I work. It does not matter what agency I call. There are no services for her, let alone support for me. The only trainings available to me for caring for my mother seem to be through the Alzheimer's Association. So after 9 years of having to put my family's needs above my career, above my ability to earn money, above my dreams for myself, I find myself back where I started with even less. My family has been struggling for generations. Generation after generation of women have scraped through life with the bare minimum to provide better for their children. And I thought and hoped that our decades of work had finally resulted in a life where I was going to be able to escape the cycle. But generational poverty continues to be a stronger force than all our education and hard work. This is women's work and therefore invisible and without value. So I will continue to be on food stamps, qualify for TANF, struggle to pay for my kids to go for a week or two of summer camp, say no to their reasonable requests because I can't afford them. And while they have to deal with the decline and inevitable loss of their grandmother Mita, they have to watch their mother work hard for no pay, watch me mourn my loss and theirs. This disease does not have boundaries. It lives in my mother, but it twists its web into all of us through sadness, struggle, loss of memory, loss of income. It has embedded itself into every aspect of our lives. That's why my family is here, living an impromptu extended tropical vacation, because we're so sick of being sad all the time. We don't have much time together, but we can go on an adventure and be warm and have a tiny bit of fun amongst the crushing weight of the inevitable. Thank you for your time.
Thank you so much, Erin and Pam. I'm a little speechless right now, but thank you for sharing your story and the emotional and physical and mental and financial impact on your family. And I hope that wherever you are, I thought you might not be in East Middlebury, given how you're dressed. I hope you're having a good time. So thank you so much for your time today. And if it looks like you were reading, so if you are able to submit your testimony in writing, that would be wonderful. And so we can share it with others. Thank you so much for being here today and sharing your story.
Can we just send it to you, Ruth, since we have your email?
That would be fine. If you send it to me, I'll make sure to get it to our committee assistant to post. Yeah, thank you so much. And I hope we're able to do something that will help you and enjoy your vacation together.
Thank you.
Yeah, my next constituent who's here with us today was actually a student of mine last semester at Middlebury College. And all of my students were required to give speeches, and she gave a speech about her grandmother and her experience with Alzheimer's. And so I invited Caroline Siegel here today to share that story with us. So thank you. Caroline, if you want to officially introduce yourself and go ahead.
Yeah, first, thank you so much for those testimonies. They were really powerful. Hi, my name is Caroline Siegel, and I'm a student at Middlebury College in Addison County. And it's an honor to have the opportunity to speak to you today. I apologize in advance for any pauses or difficulties because I actually tested positive for COVID-19 yesterday. I'm feeling a little sick, but felt strongly that I should be here to share my story with all of you. My grandmother, Lisa, was diagnosed with early onset Alzheimer's at the age of 60. She received her diagnosis in 2002, only 6 months after I was born, and lived with this devastating disease for 18 years until she passed away in April of 2020. I never truly got to meet my Nana. I've heard the most incredible stories of her spunk and charisma. I know that she loved to dance, ski, and play with her grandchildren, but I don't remember doing any of this with her. The only moments when I saw her passion for life was when we played her favorite music. I am forever grateful to artists like Stevie Wonder, Frank Sinatra, and Aretha Franklin for allowing me to connect with my Nana, if only for a few minutes at a time. Instead of my Nana teaching me new things as I grew up, I had to take care of her. From a very early age, I remember going with my mom to visit dementia care facilities and listening to her talk on the phone about various clinical trials. My grandma lived in my house for a few months when I was 8 years old, and in all honesty, it was really scary. The hardest thing I've ever done was trying to remind my Nana who I was each day. Alzheimer's is truly a disease that affects generations, and there's no way to hide it from even the youngest family members. My Nana was the glue of our family, and it always felt like we were incomplete without her fun-loving presence. It was devastating watching my Nana become a shell of her former self, and I'm very fearful of the same fate for other family members, including my own mother. It is imperative that we spread awareness about the prevention and treatment of Alzheimer's. With your support of this bill, we are one step closer to finding a cure and saving other families from enduring what I did for the first 18 years of my life. Thank you so much for your time and this opportunity.
Thank you, Caroline. I'm sorry to hear that you tested positive. I hope that you feel better soon. And if you're able to send your testimony along to me, I'll share it with Erin and others as well. Thank you so much for being here today and sharing your grandmother's story.
Of course, thank you.
Yes, on behalf of the whole committee, thank you. Thanks for being here. And please do take care of yourself. I'm sorry to hear about the COVID test. Hopefully you'll get through it quickly.
Thank you. It's
All
not too
right.
bad.
That's good, but just even a little bit is not good. We know that. Do you have, Lisa, you are here, this, you are not, so Senator Hardy, is Lisa also your constituent?
She is not, but I'm
Okay.
happy to introduce her and welcome her to our committee, or you can, Madam Chair.
Oh, we'll both do it. This is great. So, Lisa,
Madam Chair, Lisa came from work that I've been doing with her and is a constituent with a short story to share about her own experience caring also as a female daughter caregiver for both of her parents. So thank you for adding her to the
thank
list.
you. This is terrific. I think the theme that we're hearing actually is are the female caregivers and how difficult that is for our for women in our state. So, and we don't want it to be invisible. That's why we're carrying out this this work. So, Lisa, welcome. Why don't you introduce yourself for the record, and then we'll go ahead. And I will say, if you have written testimony, anyone who is going to be testifying going forward, it would be extremely helpful to have you send your testimony in. It will help us understand how we can improve the bill going forward. So thank you. Okay, Lisa, go ahead.
Thank you. So my name is Lisa Pratt, and I just want to thank you for the opportunity to be here. I do have a written testimony, and I'll share it with you. Meg has it, and I have her email address, so I'll pass it along to her for her to pass along. In 2018, I lost my mother to Alzheimer's disease. Less than 2 years later, I lost my father to Lewy body dementia. It's really hard for me to summarize the impact of caring for them over the course of so many years in just a few minutes, but I'm certainly going to try. When my mother was first diagnosed with Alzheimer's disease, my father had over $400,000 in his retirement account, and they lived independently in their home with no assistance from others. While my mother was able to remain in the home until she passed, it required my brother and his wife to move in to take care of her. Both of them had full-time jobs of their own, so we had to use we had to hire in-home caregivers and used adult day services to supplement. I took over all the finances and coordination of care, which in and of itself was pretty much a full-time job. I think as Aaron mentioned earlier, and Pam mentioned earlier, it's really hard to figure out those systems and navigate them. They're complicated, and it's hard to figure out where to get those services. So that was difficult for me, and also helping care for my parents, all while working a full-time job and raising a child of my own. Eventually, we had to put my mom on hospice care. They provided us with some amazing medical care. It was probably one of the best services that we had during her time, but still didn't offer any caregiving services. After my mom passed away, my dad declined significantly. Unfortunately, his needs far surpassed our ability to care for him in the home, and we had to place him in a dementia care facility where he lived out the last 16 months of his life. We used hospice care services to help care for him as well. By the time my father passed, there was approximately $30,000 left in his retirement account. He was getting really close to running out of the funds to pay for his dementia care facility. I think we maybe had 2 or 3 months worth of funds left, and we're starting to be concerned about how to keep him there. It took the resources of my entire family, in-home caregivers, adult day programs, hospice care, a dementia care facility, and my father's entire life savings to care for my parents through their battles with dementia. It also took a huge toll on my entire family that we're still trying to recover from today. But without affordable care options to help care for them, we had no choice but to step up and do it ourselves. Finding the resources we needed wasn't easy. We did eventually contact AgeWell Vermont, and one of the things they recommended to us was an estate planner. We were fortunate enough to find one that was very knowledgeable about the resources available and worked with us to plan our finances and our care options given the resources we had. Eventually, that led to more helpful contacts in other organizations, and over time, we were able to coordinate the care we needed to help us in our situation. We were lucky to have the financial resources and family members who could help, but not everyone is so fortunate to have these things. We should be doing more to care for those with dementia and not putting so much of the burden on them or their loved ones to figure it out for themselves. Thank you.
Lisa, thank you. Again, all the stories that we're hearing this morning, all this is so powerful and moving. And it really reinforces how important it is for us to take up S206. So thank you very much for being here.
Thank you.
So we're going to move on. We have 3 more folks to hear from on S206. And Angela, you are here. I think the order that we'll go in will be to have you go first from Dale, and then Jessa Barnard from VMS, and then Devin Green from the Hospital Association, unless there's anyone who wishes to, has a burning schedule, a schedule issue. Okay. All right, good. So welcome and glad you're here. Please introduce yourself for the record and we'll hear your testimony.
Great. Thank you, Madam Chair and committee members for having me today. For the record, my name is Angela Smith Jang. I'm the Director of the Adult Services Division at the Department of Disabilities, Aging, and Independent Living, otherwise known as DALE. The mission of DALE is to make Vermont the best place to grow old or live with a disability with dignity, respect, and independence. And absolutely the topic that we're talking about today, Alzheimer's and related dementias, is an important piece of the work that we do at DALE in trying to achieve that mission. What I wanted to say as well, in addition to this topic really aligning with our work at DALE, it aligns really well also with the principles of the Older Vermonters Act that was passed in 2020, as we seek to ensure that older Vermonters have financial security, optimal health and wellness, family caregiver support, social connection, and in a coordinated and efficient system of services and supports. These are all things we are working towards as a state, as an overall system. I won't echo the statistics that Meg has already shared around the numbers of Vermonters with Alzheimer's now. We know that that number is growing. We are seeing in our programs administered by DALE both Older Americans Act programs, as well as long-term care programs like Choices for Care. We're seeing a growing number of people with dementia, Alzheimer's and other forms within our programs. And we know that it has a significant impact both on individuals, families, and our healthcare system and our long-term care system. So this is an issue that we at DALE talk about every day in one way or another as we serve more people with dementia. And there is really good work happening to try to better address ADRD within our systems of care. As Meg noted, through a grant from the Center for Disease Control, CDC, the Department of Health is working on a state action plan for Alzheimer's and healthy aging with the goal of increasing awareness, diagnosis, improved treatment, and support for caregivers. The development of this plan has included many stakeholders. It will include measurable goals and strategies, leverage key partnerships and initiatives already underway, and will be finalized this year. In addition, DALE and the Department of Health collaboratively facilitate a work group with healthcare leaders from the University of Vermont Medical Center, Memory Center, the Center on Aging, and others that we call it the hub and spoke Alzheimer's work, that we have a focus on increasing early detection and diagnosis at the primary care level. And we've developed multiple types of education opportunities related to ADRD for healthcare providers, particularly PCP practices, an ECHO project, online modules, consultations with experts. Meg spoke to those as well. So that work is ongoing to try to really disseminate better education to ensure that people receive that early diagnosis, which is so critical to then receiving the connections and resources and supports that are needed. A particular initiative within Dale that I just wanted to briefly mention is that we're working with our area agencies on aging across the state, the AAAs, to disseminate an evidence-based caregiver assessment tool called T-Care that will better identify caregiver stress, burden, and needs, and connect caregivers with resources, whether that be counseling, education and training, respite, or other resources. While the AAAs already serve thousands of caregivers through the Older Americans Act programs and dementia respite grants, this additional evidence-based assessment will allow a deeper and more individualized understanding of each caregiver's experience in order to connect them with the most appropriate resources to meet their needs. So a couple of comments on S206. Specifically, I wanted to focus on sections 1 and 2 as it relates to the Governor's Commission on ADRD. Dale is supportive of the spirit of this bill in seeking to better address Alzheimer's and related dementias. It's an important goal and it really deserves this real focus. We have a few concerns with the bill as written as it relates to the work of the commission. So I wanted to specifically touch on those. And the Governor's Commission on Alzheimer's disease and related disorders, the purpose is to advise state agencies on policy. And Dale provides administrative support for that commission. I've participated in the commission, both providing that support for a few years and now and participating as the Director of Adult Services since 2016. This bill includes a substantial body of work for the Governor's Commission, which currently does not have dedicated funding and has a limited capacity. It requires the Commission to develop and carry out an assessment of all state programs that address Alzheimer's disease and create and maintain an integrated state plan to overcome Alzheimer's disease. From my perspective, this does not seem like a very feasible initiative for the Commission with the current resources available. That said, the Commission has played an important role in advising the Health Department on the development of the new State Action Plan on Alzheimer's and Healthy Aging, providing significant input into its development, which is right in line with the Commission's purpose and its capacity. A few challenges with the goals in the state plan as proposed in the bill in Section 1. The focus of the plan is on overcoming and fighting Alzheimer's, but there is little focus on the quality of life of people living with dementia and the quality of life of their families who support them. There's not a mention of family caregivers in the goals of the plan, despite the fact that family caregivers play such a huge role in providing services and supports for people with dementia. Rather, it focuses on accelerating the development of treatments, which is, from my perspective, not the role of Vermont. It does not address the fact that the Department of Health, already in collaboration with Dale and partners, is already in the process of developing such a state plan. And so I question whether another plan is needed, or is it duplicative? Or is there an opportunity to build on a current plan that's already in the works? In Section 2, The bill calls on the ADRD Commission Chair to appoint 3 members of the Commission to serve as a work group for the purpose of making recommendations on continuing education requirements related to diagnosis, treatment, and care of patients with cognitive impairments. The work group will be required to focus on a range of healthcare professions, consult a number of professional organizations and associations, and would have only 4 months to report its recommendations. Dale remains concerned that there's not the time or the expertise among the current commission membership to be able to adequately fulfill this requirement of the plan. Back to our focus at Dale. Very much focused on building a more dementia-capable workforce across our continuum of care. So thinking about the work I mentioned in working to educate and support primary care, as well as ensuring that everyone supporting people with dementia in their home or a residential care facility or a long-term care facility has the training and education to be able to serve people with dementia the best that we can. So we're continuing to seek funding and use funding that's coming to Vermont, for example, through the enhanced FMAP funding to increase the level of education and training offered to our entire workforce serving people with dementia. So that would be everyone from our personal care attendants in the home up through the continuum of care. I would be happy to send you as well, given the focus here on family caregivers, in 2020, in advance of our state plan on aging development, we did a pretty comprehensive survey of older Vermonters and family caregivers and asked a range of questions around their experiences. And there's some good information in that survey that might be additionally helpful in thinking about opportunities to better serve the population. So I'd be happy to send that to you if that would be helpful. So I will end by saying thank you to the committee for really taking up this important issue. And I am happy to take any questions.
Thank you very much, Angela. The load of work that you face is significant. As people are talking, and I'm thinking about the request for care management and a continuum of care, and then layering on that the 13,000 or 17,000 Vermonters currently with or expected to have cognitive problems or Alzheimer's is it's an unbelievable heavy lift, to say the least. So I do have a couple of questions for you, and we'll take a minute here to let the committee ask questions as well. And that one is about the care management piece and what, if anything, in the action plan do you see coming out that will improve or increase the care management available to with folks with cognitive impairment?
I'm really glad that some of the other witnesses spoke to that. I think it's an important and an unfortunate gap in our system that we don't have for people who don't qualify for Medicaid, whether it be clinically or financially. There aren't as many options for that kind of care management. I will say that the Older Americans Act reauthorization in 2020 expanded the ability of the area agencies on aging to provide care management to people with younger onset Alzheimer's. Typically, the area agencies on aging only serve people age 60 and over, but that reauthorization now allows the AAAs to be able to serve people with younger onset Alzheimer's as well. So that is one option that's available. Again, we need to build out the capacity of those care managers within those agencies and their training and education related to dementia, even as we're trying to expand the opportunity there. I would say we have good case management agencies within our system. It's just that typically the workforce challenges right now are getting in the way of being able to serve more people, and there definitely is a prioritization of those in greatest economic and social need.
So I have a couple more questions, and I think Senator Hooker, did you have your hand up as well? Okay, good. I'll just try and finish up. So is there anything in the budget for additional resources or any of the work that we're talking about here today? Is there anything in the governor's proposed budget on this? We haven't looked at it yet. We will ultimately, but perhaps you could help us.
I don't believe that there is something specific to Alzheimer's and dementia within the governor's budget. There is increased funding for long-term care, for providers and choices for care and those programs, but not specific to this issue, I don't believe.
Okay, and that, because that would cover then, in our interest would cover things like choices for care, where folks receive in-home services and support. So do you know if there's any support for that or programs like that, adult day programs or others within the budget?
I do know in the Dale budget, there's a 3% increase to all choices for care providers. So that would include case management providers, direct care, adult day, et cetera.
Okay, good. Thank you. Well, and we'll be keeping our eye open for some of the things that we're learning about today. This is very helpful. Another thing that you mentioned was the Alzheimer's or the Cognitive Impairment Hub and Spoke, and then integrating work with our primary care docs and folks. So that sounds to me like an opportunity for blueprint expansion into this area. Is that something that the agency is thinking about?
Very timely question. Our Hub and Spoke team meets tomorrow, and we've invited a representative from the Blueprint for Health to come and learn about what we're doing and consider how to support the endeavor. So I think that does make a lot of sense.
That's good, because that kind of meshes with what our committee is at least looking at. We haven't made any decisions, but we've been looking at that. And I do know that our healthcare reform director has put off the final report on Blueprint, but we'll be getting it soon, and maybe we'll hear more about what your discussion is. Let me just check and make sure I don't have any other questions at this point. I'm sure I do, but thank you for your comments specifically on the bill, and we'll certainly have a discussion as we go through the bill for markup, and that your comments will be important to us. But we need to make sure that they're in writing. That's all. We need to get them. Thank you. That'd be good. So Senator Hooker, you had a question?
Thank you. Thank you, Angela. I'm pleased to hear about the work that's going on with care management. This is across the healthcare continuum. I think that we're trying to coordinate care across the continuum. My question is, how will this relate to people who are already providing the care, the people that we've heard from today, the daughters, the sons, the grandchildren who are providing care? You spoke, Angela, about the workforce issue. We know that that's huge here. How can we incorporate these people and have them receive the resources that they need, the help that they need to continue this care? Otherwise, the workforce issue is just going to explode, and we're going to be in worse shape. So what connection is there with Dale and family members as far as giving them some kind of compensation?
Right, that's a great question. Yes, I mean, there is really strong research available to show that supporting the family caregiver is critical to being able to help people stay in the community as long as possible. And that the caregiver burden is very real, that caregivers, their health outcomes deteriorate over time with the amount of caregiving that's involved, especially for people with dementia. So there are a few programs already available to family caregivers across the state. And I think there's opportunity to really build and expand upon those as well. So through the Area Agencies on Aging and the Older Americans Act funding, there's specific funding designated for family caregiver support. And that can include a range of services from access assistance, which is kind of like case management, in connection to resources, education, training, counseling, and respite. There are respite dollars available to families, not enough for sure, but there are respite dollars available to families that could be used to bring someone into the home, to have a short-term stay in a facility, or to go to an adult day program as well. For those that are not eligible for long-term care Medicaid, our moderate needs group program is also an option for people, which has a higher income threshold and a broader clinical eligibility. So many people with Alzheimer in the earlier stages of Alzheimer's may be eligible for moderate needs, and that can provide things like adult day to allow respite for family caregivers, as well as case management and homemaker services. So there's a few different available resources. It's certainly not enough. And it's something, we even have a map of Vermont that shows the different places where there's adult day, where there's caregiver support groups, where there's access to additional training and memory support, that we're working to really try to intentionally build out with our partners in the Aging Services Network.
And I'm pleased to hear all of those things, although I hope that we can open our adult daycare in Rutland again because it's been closed. But I guess my question is, how can these people be paid for the services that they're providing? Not just trained, not just respite. How do they get paid so someone like Aaron has this job and is being paid for it? I mean, how can we incorporate family members into these personal caregivers?
Yeah, that may be a question that's bigger, that may be for others beyond myself. What I can say is within Choices for Care, that is an option for people. So for those people who are eligible for Choices for Care, your family caregiver can be paid to provide care for you in your home, whether that's your adult child or your spouse or another relative. So that is and it is certainly an option within Choices for Care, but we don't have that option for the broader population.
Okay, Senator Hooker, because you asked a question that I was going to add. This is a really important conversation, and I guess the question is, first of all, can we see the map? That'd be great. And then the second one, again, I want Senator Hardy and Senator Cummings each have questions, but the other question is, in terms of a policy priority by Dale, is the policy priority for home care by relatives, or there are people who don't have relatives next door down the street? So is there a policy priority to have broader programs generally to support people? I know we don't, in my district, we have one institution that's a care facility for Alzheimer's patients. And I've visited people there many times, friends and others. So what is the priority that the state might have around this area?
That's a great question. I would say that we are really prioritizing in alignment with the recommendations from the Adrd Commission, working to create a dementia-capable workforce across our system of care, which includes both paid, I would say includes both paid and unpaid caregivers. And so that really, we're really trying to take a multi-pronged approach in trying to do that, recognizing that we have significant workforce challenges within our system right now, and likely for some time to come. So we need to better support family caregivers. We need to increase the availability of volunteers to provide respite, and there's a number of pilots in the works to be able to build a respite core specifically to do that. And then we need to build out the real training and support for our paid workforce as well, whether that be in home and community-based services or in facilities. So I would say that is really our priority, and we're trying to leverage, the funding available and the opportunities available to do that.
Okay, we have two more questions, and then after Senator Hardy and Senator Cummings ask their questions, we probably should move on to the next topic, but thank you very much. Senator Hardy.
Oh, Senator Cummings, did you want to go? You were poised. It's fine. If you
I
want
was
to
poised.
However you want to do it.
No, I just wanted, we lost, Senator Hooker mentioned, we lost 2 adult days. I worked at one in Barry a number of years ago. I know they were always financially struggling. They were always trying to find just base financial support. A lot of their participants had no money. And just, what are we doing to help get those kinds of facilities up and running? Because they allow families to work. They allow families to get a break. And I know the Alzheimer's Association also had a respite program that would allow families to go away for 2 whole days if they have the financial resources. And it's, what are we doing? I mean, how are we I was told there was somebody that was going to open up in Barry, but last time I drove by, no one had opened up. So just wondering what's happening.
Yes, this is a real challenge for our system. Having the adult day centers are an important component within our long-term care system, and the fact that we've had 3 close since the start of the pandemic has been really challenging. Yes, Rutland, Barry, and Newbury were the 3 that have closed, that have not reopened. Everyone closed originally, right? But everyone else has reopened with a lower capacity level. So Dale has been in ongoing conversation with the Aging Services Network within those communities to really have conversation around what does it take to do an adult day, how, who is interested, providing that, answering those questions about what is it, how do you get certified, what are the rules and regulations, all of those things, providing as much TA as possible to anyone that might be interested. I think it's been a challenge given the pandemic for anyone to want to jump into this right away. But I do think that there is community interest in continuing to explore that. For example, I was just on a phone call with the Southwestern Vermont Council on Aging in Rutland on Monday. They're doing strategic planning. We talked about adult day being a gap in their area, and how the AAA can really play a role in facilitating some movement there. So I'm hopeful that we'll get there, but unfortunately, I don't have immediate news of an adult day opening up right away.
Well, I think the bottom line, as with childcare, is are they financially viable? Because no one's going to open it up if if they can't make a living doing it, they can't pay their staff. And right now you can't get staff, but it comes down to money, as it frequently does.
Right.
And, is there technical assistance at helping people look at what are the common denominators in the successful adult days? How do they set up financially so that you might be able to recreate that model?
That's a great question. I mean, we have some really amazing adult days in Vermont who have been very successful. I think it requires an economy of scale to then be able to be financially viable. And one of the challenges in some of the smaller centers is trying to meet that threshold to be able to be financially sustainable. I think that's a great recommendation, and definitely something that we can do with the network is reach out and have a more sort of concrete, practical conversation around what does it take and what makes a successful model.
Right.
Certainly, the payment is a part of it, but there's many other components to making a successful center as well. So I think that's something we can do.
Montpelier are not small areas. I can
Right.
see where Newbury might be, but Barre and Montpelier have a large concentration of aging people, and some of us included. And they should be able to make, we should be able to make those areas go. They're central employment areas. People can drop relatives off on their way to work. So
I'm muted. I was going to say, this is going to be a terrific discussion as we go through the bill for markup, as I hear a lot of neat ideas coming out. So Senator Hardy had a question.
Thank you, Madam Chair. By the way, the Middlebury Adult Day is an amazing center, so you can use that as a model for sure. The question I had was just back to the specific language of the bill and your testimony and Meg's testimony about the plan that's proposed in the bill. And it sounds like a plan is already in the works. And Meg, I think, indicated that the Adrd or whatever it's called is doing whatever the letters are doing it. And you indicated VDH is doing it. Are you working in collaboration, or are there two things happening at the same time? Could you just clarify that for me?
Right. So the bill proposes that the Adrd Commission create the plan. There's currently a plan being developed by the Department of Health in collaboration with the Commission, Dale, the Alzheimer's Association, et cetera.
And is that through using the resources from the BOLD grant?
Yes.
Yes. Okay. So that's the initiative issue that we would like to build on, not hinder. So I want to make sure that we get the language in the bill right to ensure that we're building on that, et cetera. Okay, great. That's Go ahead.
I would just recommend, potentially, I think the folks at the Department of Health would be happy to share more information about the status of that planning effort and, where that's at and the goals and things, if you were interested in hearing more.
Well, so that was my next comment, that we'll probably bring the Department of Health in so we can understand what they're doing, and that'll inform us about the bill. But so that's very helpful. Thank you. Thank you all. And we're going to move on to Jessa Barnard of the Vermont Medical Society, and then we'll hear from Devin Green of the Vermont Alliance Hospital folks. So, Jessa, welcome.
Good morning. Thank you very much for having me. Thank you for taking up this issue. I'm Jessa Barnard, the Executive Director of the Vermont Medical Society. We represent physicians and physician assistants across the state, and really appreciate you also hearing the stories from families this morning. I think dementia and related illnesses touch or will soon touch all of us here in Vermont. My mother-in-law passed away from Lewy body dementia, and my parents, I'm currently helping them navigate these exact issues down in Bennington. So I feel this issue personally as well. And on the provider side, VMS strongly supports efforts to improve dementia care in Vermont, including efforts to improve and increase clinical education, and also to share and disseminate information regarding both medical and non-medical options for treatment services and supports. You've heard this morning a little bit about some of these efforts underway, and we think they are making great progress and really have come together just in the past couple of years to significantly increase the education available to primary care. So those include the efforts to help develop a hub and spoke model where there are kind of centers of expertise and excellence that can then support primary care providers, and also the Dementia Corner consults. And I just sent my testimony to Erin, as well as a handout that outlines kind of what these Dementia Corner consults look like. It has the lead neurologist from the memory center at UVM that you've heard referenced have open office hours with primary care clinicians to ask any sort of questions about either specific patients or diagnosis or complicated issues. And then also the Vermont Project ECHO that you've heard about, which is also a really evidence-based model of education where primary care practices or clinicians sign up for an ongoing series of education, and it's really case-based intensive education on a lot of issues related to dementia and primary care. So we feel that all of those efforts underway are really starting to gain some momentum, and that they're also very evidence-based approaches to education in primary care and among physicians. But we do, so to touch some of the elements of the bill, Section 2 related to continuing education. We, again, speaking for the physicians and PAs we represent, have some concerns around going in the direction of mandatory education. In general, we feel like mandatory, especially one-time mandatory education sessions, are not particularly evidence-based and don't tend to have extremely well-documented outcomes for improving care. And I've outlined in my testimony some more information around that. And we have a lot of experience in Vermont, for example, with the opioid trainings, where we've seen things like even it's in mandatory education for licensees. We've seen out-of-state for-profit companies come in marketing these programs as meeting the required education elements, but not being particularly evidence-based or well-developed education. We also have concerns if these become required for every relicensure cycle, they can become repetitive and not as meaningful, and may not be relevant to all specialties or the way those providers work in the field of dementia or the education that they need. So again, we really encourage the committee to learn more about the existing efforts underway, if anything, perhaps strengthen and further disseminate those. But we at this time don't feel that we need further study of educational requirements. Instead, we should be focusing on, as I said, developing and disseminating the curriculum, tools, and supports that Vermont clinicians need to provide care to patients with dementia, such as the corner consults and Project ECHO. So that's Section 2. We also have concerns about Section 3, and we appreciate Meg bringing this up. I know you haven't delved into the details of this section, but it would mandate that physicians provide family members with a specific list of information, including an Alzheimer's diagnosis, assistance understanding the diagnosis, medical and non-medical options for treatment services and supports, and information regarding how to obtain treatment services and supports. So some of our comments on this approach, we first don't think any change is needed in Vermont law to allow relevant clinical information to be shared with family when it's consistent with the federal HIPAA privacy rule, which really governs disclosing medical information to family members or others involved with a patient's care. And while we do fully support efforts to educate providers about what services and supports are available to patients and their families, we think that one of the main barriers to this happening more systematically is, in some instances, a lack of resources available in certain communities, and also uneven knowledge of those supports and services. And so rather than mandating disclosure of certain information, we really strongly support efforts to build on a centralized catalog of community resources. And I had not been aware of the map that's being developed. That might be a great example of what's already underway and a way of sharing that information further. And broken down also by perhaps how they may help patients at different points along their disease trajectory. As you all know, the needs change greatly over the course of a dementia diagnosis. And I think that's one of the things that clinicians also struggle with, is what might be helpful at, what information do you provide immediately upon diagnosis versus what do you provide over time as needs and family needs for both support and information change. We do have concerns that the specific approach to mandating certain disclosures is legislating a clinical practice, and while disclosing the information listed may be entirely appropriate and applicable to certain patients, it may not be appropriate in other circumstances. For example, it may be unclear if the patient only has early cognitive decline, or has it become a full Alzheimer's diagnosis, sort of when is the disclosure triggered. Perhaps the patient would like the information about treatment and services at a later time rather than when they first hear they have a diagnosis. Is it a violation of the statute to delay providing information, or asking a nurse case manager or social worker to provide the information rather than the physician, him or herself, since it only references physicians? And it's also unclear if it applies only to the physician making an initial diagnosis versus a physician who's involved with the patient's care later. So again, I won't go on and on. There's more concerns listed in the testimony, but I think that specific method of increasing information and supports does raise concerns for us. On the other hand, we very much support making information more systematically available that clinicians can provide, and also directly to patients and their families. So we look forward to working together with the committee as you work on this bill. Some of what I've heard this morning is very encouraging, and we would support building off of existing efforts underway. Thank you very much for letting us testify this morning.
Thank you. That is a very, very helpful information. And as we go forward, we'll look at all the testimony, and we'll try to work together as we get into the bill and begin our markup process. I think we'll probably hear from the Department of Health first before we do that, but we will be doing that. Devin, welcome. Any questions first for Jessa Barnard of VMS? Okay. Devin, welcome.
Good morning. Devin Green, Vermont Association of Hospitals and Health Systems. Thank you for having me in today on this issue. It is hugely important and impacts our entire healthcare system and our communities. I want to start from the lens that I'm sort of looking at this bill through, which include our current efforts, as was talked about with other witnesses. The Hub and Spoke program that's happening right now is an effort that is trying to address the issue of primary care providers not feeling equipped enough to diagnose Alzheimer's and dementia, and so referring people to specialists. And as you know, there can be a wait time for specialists, and if all primary care doctors are referring people to specialists, there will be a much longer wait time, and there's an inability to get those community supports and interventions into the person earlier. So the purpose of the Hub and Spoke program is to provide resources and make primary care providers feel equipped enough to make those diagnoses so that people can get to community resources sooner. That being said, as Jessa mentioned, as Lisa mentioned, we do think that there's a need for one stop for those community resources. It would be great if we had a website that both families and care providers could go to understand what's in the community, what's available, and have it all in one place. Because I think the consensus we've heard here today is that it's really difficult to navigate what resources are available when you get a really difficult diagnosis like that. So that is one thing we would ask for in this bill. So I will say, in terms of the state plan and how that works, I I'm not sure. I think, we do want to talk about ways to overcome Alzheimer's. I think the items in there are fine. I would say there's one issue that I have with the language in section 1 that says that a goal is to increase the diagnostic rate of Alzheimer's disease. I don't think we want to get into a space where we're overdiagnosing or incentivize overdiagnosis. So I just changed that to appropriately diagnose if you're going to keep that in there. But it sounds like what we really need there, and maybe it's not with sitting with the commission, but more with VDH, is just a real coordinated effort when it comes to Alzheimer's and dementia, and that we would fully support, including a website that has resources for folks. For section 2, with the continuing education assessment, we agree with the Vermont Medical Society. There is a lot of good work going on right now in terms of making and supporting primary care providers. There's Project ECHO, which is enhanced diagnosis and management of dementia by the primary care team. There's also efforts through OneCare with Vermont Health Learn. And then there's the corner consult, as Jessa mentioned earlier. I think the hub and spoke team is exploring how to make the corner consult a little bit more workable for folks, because right now it is a sort of slot for people to come in. And I think providers need more of a on-call situation with their consults, but it's still a really good resource and a good start. And I just don't want to get into a situation where we're taking away from these efforts. I'd rather support the current efforts that are coming rather than doing a sort of gap analysis and any mandatory CLEs. For section 3, with the care of patients with cognitive impairments, Jessa spoke to the issue of requiring healthcare providers to report diagnoses to family members. I agree with her analysis. I'm not sure how much this would add, and making it a requirement. I do worry that it will get to that. It will sort of backtrack on all the work we've done with primary care providers to try to support them. If they feel like they're legally obligated to tell family members of a diagnosis in a sort of murky consent situation, they may just say, okay, I don't want to do the diagnosis at all. I'm going to send this person to a specialist to deal with it. So I don't think that piece would be supportive of the efforts that we're trying to make with this hub and spoke model. In terms of the hospital plan, I would say that really appreciate Meg supporting taking that piece out. We are at this point, another effort that's happening on the state level is, yesterday we had 113 people in our hospitals who were waiting for placement in a more appropriate place. So they're waiting for placement, they're in a hospital bed because there is no appropriate place to send them to at that moment. We believe about 20% of that group is likely people with Alzheimer's or dementia who may be suffering from some behavioral interruptions and may be difficult to deal with due to some of their behaviors from their disease. And so we would like the focus to be on shoring up the workforce, which we know is the issue for why we cannot place these people. There are many long-term care beds available, but there's no placement for them because the workforce is not there to staff them. And so we would really appreciate shoring up the workforce rather than creating a hospital plan. We don't want to give the impression that the hospitals are not homes for people, and a lot of these patients need homes. So we don't want to put the burden on hospitals to create a plan when what we really need to do is shore up our long-term care workforce more so that people can get into the place where they need to be to get the best care available and in the least restrictive setting. So we would also ask that that provision be taken out as well. Again, thank you for your support on this issue, and we're happy to provide our perspective or answer any further questions.
So thank you. This is very helpful. If you can get your comments in writing, in particular, about the bill, so we can look through that as we're doing markup. It sounds like there's some consistent comments and themes through the testimony that we've heard. So this is extremely helpful to us. And we are going to be hearing from folks in the Blueprint and Lincoln with Hub and Spoke at some point. But I think importantly for this bill, Department of Health, will the Department of Health, from your perspective, be able to speak both to BOLD and to ECHO? Meg, maybe you can answer that, or Jessa?
I'll let Angela answer that.
Angela will answer it.
I believe they will be able to speak.
That would be great. All right, because we'll bring them in so we get a clear picture of everything that's going on. We don't want to have to reinvent the wheel. Senator Cummings.
Yeah, there was an issue, it came up last year, the year before, with the way we are rating nursing homes. Like, if there is an incident, you get scored down. So I go looking and I've got a bad score. But a lot of that happens because somebody with Alzheimer's acts out, which they do. And so nursing homes are very reluctant to take people with Alzheimer's. And that ends up with very expensive specialized units. I've heard the number like 125,000 a year. Is that, am I really off on that? But we might want to look at, so they're in the hospital because nobody will take them. And they're taking up a bed they really don't need. And that's an issue we need to look at.
Yes, Senator.
Yeah, go ahead, Devin, you wanted to comment.
No, I agree 100% that we need to take a look at that issue. I think we need to plan for that and think of some creative solutions, because part of the issue is the federal regulations and those star ratings. But I think in the meantime, because right now we need to sort of stanch the bleeding, and that's in workforce and just being able to open up enough beds to take people in general, so we don't have 113 people waiting in hospital beds now. So agree 100% that longer term, we need to figure out a solution to that. In the meantime, we really need to focus on workforce.
Okay.
So, and this committee is probably more aware of workforce issues in the healthcare environment than others, but we'll be working on workforce. That is without saying. We'll be working with our Appropriations Committee, our Economic Development Committee, and others to improve workforce for Vermonters and others. So, but I think it's also important, as we're looking at this, that if there are things that we can put in place that build the system and repair the system, because we've seen tragedy during COVID, the adult days is just one expression of that. But as we go forward, if we can mend the system a little bit through some of our legislation, we'll also do that, knowing that workforce continues to be a huge issue. Oh, thank you. Okay, so this has been helpful. Please send your testimony in if you have not already, and we look forward to receiving it, including the map. And then we'll hear more from Department of Health and come back to the bill and do some markup, walk through the bill more thoroughly with our legislative counsel. And so that's it for that topic for today. Thanks all for being here. Appreciate it. So we're going, here's what I'd like to do, committee. There are 7 people waiting to testify in the waiting room. And we're going to take, Aaron, I know we are on a crunch time, but we're going to take a little break. We're going to take a 5-minute break. Please come back at 10:38 and we'll be ready to go. And Aaron, you can let folks in. I think we don't have to go off.